Welcome to our YouTube review for exam 2. What I'm going to do is to take the review sheet and to give you heads up as far as what to emphasize and what's important and so forth and so on. So it's going to be about 10 questions or so from each section, because you have your renal, you have your electrolyte, you have your acid base, you have the nervous system, and the pulmonary and vascular. So it's not quite 10, it's about 8. Mainly objective questions, mainly multiple choice. All right, now, starting off with vascular pathophysiology, atherosclerosis, also called hardening of the arteries, is the formation of plaques in arteries. They come about because arteries are high pressure and they take a beating over time. So very often hypertension is to blame, as well as people get older. So whenever you see things that are highlighted or underlined, that's something to pay attention to. The main thing, since you'd get more information in a nutrition course, is the fact that cholesterol should actually either go into making sex hormones, or it should be excreted in feces. As people get older, then that can be compromised because they're not making either they're not making sex hormones or they're reduced, so that the cholesterol is not being used for that, and very often then the cholesterol is deposited in arteries and starts the plaque. It's called a silent disease because you don't, if you're not looking for it, then in days of old, people would just drop dead of a heart attack and have no indication beforehand that there was really anything wrong. All right, so on to our next slide. Okay, so what you have here is, I'll go into stable and unstable plaques in a sec. This is just introducing the next slide. So things like fibrous cap and unstable plaque, collagen, thrombus formation, coronary occlusions, thromboembolisms. Remember that a thrombus is any blood clot in an unbroken blood vessel, and you can end up closing the blood vessel, like the coronary artery, which would lead to ischemia and hypoxia. All right, this is something that I definitely want you to know. So if I had a multiple choice, and I would say on the multiple choice, A, stage 1, damage to tunica intima; B, stage 2, fatty streak formation; 3, formation of unstable plaque; and stage 4, rupture of the unstable plaque. What I would want you to be able to match up is what's happening during those stages. So stage 1 and stage 2 are silent. What happens is that innermost lining of the artery, called the tunica intima, tears. And that could be due to hypertension or old age. Now, when that happens and you split the two layers, that allows the entry of cholesterol, inflammatory phagocytes. And the phagocytes are trying to get rid of the cholesterol, but it's very, very difficult for them to do that. So stage 1 is set up once the tunica intima is damaged. Stage 2 means that you have formed the plaque, and as time goes on, the plaque is going to get larger. It's called fatty streak because cholesterol is white in color, and as the poor phagocytes are trying to engulf and get rid of the cholesterol, it ends up not being broken down, and the streaks of white that a pathologist would see in the phagocytes would reminded them of fatty streaks. Now, stage 3 and 4 are symptomatic, and they tend to come pretty close together. The unstable plaque. So if a pathologist saw foam cells, these are merely phagocytic cells, like macrophages, that are so full of cholesterol that they're just so overwhelmed that the cell totally appears white and a little bit, the edges bleb out a little bit, so it reminded somebody of foam. And what the body does to try to stop the rupturing is to put a fibrous cap on it, but that's just going to hold for a short period of time. Stage 4 is when it ruptures. Now, when the unstable plaque ruptures, it's going to expose collagen beneath, and that's the trigger for thrombus formation. So, and again, anything that's underlined, just to know what it is. And then once you've got the clot, it's going to, again, have some pressure on it because the blood does want to go through. And so small little floating emboli are going to be formed, and very often they then will downstream totally occlude the coronary arteries, and the person will have a heart attack. All right. Deep vein thrombosis. So that was about arteries, your arterial sclerosis, and now you're getting deep vein thrombosis. The main cause is going to be where a person is bedridden. And venous return is difficult if the muscles, skeletal muscles aren't working. So you get stagnation of blood, especially around the valves in veins. And stagnated blood, as we all know, causes clots. So the thing is that when the clot starts to move, the veins get larger as they get to the heart. So that's not a problem. Problem is that the right side of the heart is going to pump it into the pulmonary arteries. Arteries get smaller. They get into arterioles, and they divide and get even smaller. So that's when the clot lodges in the lung. And depending on how many embolisms and the extent and degree of the clot and the occlusion and not being able to exchange respiratory gases will depend on how lethal this is. But in all cases, the deep vein thrombosis, you're worried about the clot then getting caught in the pulmonary artery circuit, and then that would cause a pulmonary embolism. You can't get gas exchange, and the person can quickly die. Aneurysms, again, hypertension, in this case, hypertension tends to be the culprit rather than deep vein thrombosis. Now you're talking deep vein thrombosis of veins, aneurysms of arteries. So over a period of time, the high pressure, especially if you have systemic vasoconstriction, is going to cause the walls to bulge out as they weaken. And that's the aneurysm. If the aneurysm blows, depending on how large the artery is, you can have an aortic aneurysm, and the person can bleed out in a very quick period of time. The other aneurysm I want you to know about is aortic dissection. And in an aortic dissection, the tunica intima peels away from the tunica media due to damage, and that causes a false channel. So blood is going to go into one part of the aorta and then the false channel of the aorta, where you can have clotting occur, where you can have an aneurysm occur, and that is a serious medical emergency. And the thing that you worry about is that that would end up either clotting and causing all kinds of problems, especially in the coronary artery system, or that it could burst and the person could bleed out. All right, hypertension. Hypertension is just arteries. Because arteries are high pressure, they are able to do vasoconstriction and vasodilation to regulate blood pressure. And this just goes into what can happen in hypertension. So damage to the tunica intima can start arteriosclerotic plaques. Second one, the increase in peripheral resistance due to vasoconstriction of arteries can make the heart work more. And that's going to cause hypertrophy, especially at the left side of the heart. And then the hypertrophy is going to try to overcome the ischemia, but eventually the heart will fail from overwork. And the third one is that weakened arterial walls can lead to aneurysms, which can rupture. So that's it for vascular. Pulmonary patho. Do know the two respiratory failures and what they represent for a couple of questions. You can either have hypoxic respiratory failure, too little oxygen in arterial blood, or hypoxic hypercapnic respiratory failure, and that's spelled wrong, but that's okay, respiratory failure, where the oxygen level drops but the CO2 level rises in arterial blood. So hypoxic, low oxygen, hypercapnic, high CO2. And the other thing about pulmonary patho is to understand at times what's going to drive some of these pathologies, and that's the ventilation perfusion issue. Ventilation exchange at the alveolar sac of respiratory gases, and perfusion is the flow of blood via the pulmonary capillaries to the alveolar sac. They should be equal. And what is going to happen is that if they're not equal, they will try to compensate. So, for example, if there is a decrease in ventilation due to a COPD like emphysema, then perfusion is down. And the way that you get the ventilation, which is down, and the perfusion to be equal to ventilation is to do vasoconstriction. This is a chronic disease. It's going to be over a period of time. That's pulmonary hypertension that is caused by that is going to put a distinct extra load on the right ventricle, which is going to undergo an enlargement because of hypertrophy, and that is called cor pulmonale. And if that is not remedied, the right side is weaker than the left, and so over a period of time after the cor pulmonale, it can then result in the total collapse of the right ventricle and death. Okay, now we got ourselves into our ARDS, our acute respiratory distress syndromes. The three of the COPDs, and then we'll get into the other pathologies. Okay, ARDS, acute respiratory distress syndrome, is an emergency. It is a type 1 hypoxic respiratory failure. On the exam, it's going to be the reflux of vomit into the lung alveolar sac, and that is a type of pulmonary edema, which is going to make it impossible for oxygen to be able to diffuse into the pulmonary capillaries because oxygen needs hemoglobin in order to dissolve. And that isn't occurring in the vomit-filled alveolar sac. So it becomes an emergency because the person is going to not be able to oxygenate their body. Now, that's an acute problem, type 1 hypoxic. The COPDs, and actually all the other ones that we'll talk about, are type 2. Something's going to happen in this case, the chronic obstructive pulmonary disease, that is going to end up creating a situation where the bronchi and bronchioles are either going to be so constricted and or have so much mucus that both inhalation and exhalation is going to be problematic. It's very difficult when breathing bronchioles, the conductors of the breath, become so small that you're not going to be able to adequately ventilate. So what you have with asthma and chronic bronchitis, asthma is going to be a IgE, allergy reaction to some trigger that's going to trigger an asthmatic attack. Versus chronic bronchitis is brought on by smoking, long-term smoking. What's happening in asthma is that the person who is exposed to their asthmatic trigger is going to produce the IgA on mast cells, and the trigger then is starting the inflammatory reaction with the mast cells releasing histamine and leukotrienes. Remember leukotrienes, put that in, because when you take, when you end up taking pharmacology, you're going to find that you're going to have, for an asthmatic, antihistamine as well as anti-leukotriene drugs. Okay, what they two very potent histamine and leukotrienes do is they will make the bronchi and bronchioles extremely small, and they will also be able to get the goblet cells that make mucus to up the mucus production. And between those two, it's just extremely difficult to do either inhalation or exhalation. And then with the chronic bronchitis, it's a very similar outcome, but it's going to be caused by the chronic smoking. Because what's happening with the smoking is that the smoking is going to cause the goblet cells to up their production of mucus, and you are going to have inflammation. Inflammation in and of itself can also lead to bronchoconstriction, is the word I'm trying to get at, bronchoconstriction. And with the bronchoconstriction, then you, and the mucus production, you're going to have the same type of problem. You're going to have ventilation be very difficult. On the other hand, emphysema, the third example of a COPD, has a very different pathophysiology and actually a very different way of destroying the lung. Smoking, long-term smoking is the cause, and what is going to happen is over a period of time, the macrophages in the alveolar sac get remodeled by the smoke and the chemicals in the smoke. And they are going to release proteases, which is incredibly pathological because the proteases break down protein fibers like elastin. So the elasticity of the lung becomes lost. The other thing as well is you end up having the proteases start to destroy the alveolar sacs. And so with the chronic bronchitis and the asthma, it's all about bronchoconstriction and bronchodilation and mucus production. In emphysema, it's all about destroying the elasticity of the lung by destroying elastic fibers, and it's all about destroying the alveolar sacs, which is permanent and it cannot be repaired. So emphysema is a progressive chronic disease. Now, the only pneumonias that I'm going to go into are the viral and the bacterial pneumonias. And the main thing is not, there might be a 2-point question on this, but that's about it. What I want you to know about both of these bacterial and viral pneumonia is they both produce pulmonary edema. And this difference in the patho is that in bacterial pneumonia, the bacteria get somehow into the lower part of the lung, and you're going to then have the macrophages try to engulf and kill the pneumococcal pneumonia, for example. What will happen then is sometimes you have too much or, some way of overwhelming that macrophage. The macrophage is going to start inflammation. It's going to try to get rid of all that bacterial infection, but very often overwhelmed. And the inflammatory reaction, which is trying to get rid of the pathogen, is what causes the pulmonary edema. Viruses, now remember, viruses are just DNA, RNA in a protective coat. You know that viruses have to get into cells in order to replicate. In viral pneumonia, it could be like, try again, pneumococcus pneumonia, not pneumococcus pneumonia. I'll think of the other types of viral pneumonia. But with the virus, they're not going to be attacking the cells of the alveolar sac. They're attacking the cells of the small bronchioles that are at the end and balloon into the alveolar sac. So when they start to grow and multiply in those cells, it's going to start inflammation. And the edema, because of gravity, is going to get pulled into the alveolar sac and again cause problems with ventilation. All right, tuberculosis, TB. The big thing with TB is to know the difference between how the body addresses the initial infection versus a reactivation. So it's caused by the bacteria, Mycobacterium tuberculosis, and this has learned how to deal with the immune system. When you are initially infected, because perhaps you inhale some affected droplets. Oops. Okay, sorry about that. I got a delivery. Okay, so TB, the first time that you are exposed, your body's T lymphocytes are able to stop the progression of the disease. And they wall off the remaining TB bacilli in a little tubercle or nodule, and there it's going to stay. It does a way of surviving under very low oxygen and nutrients, and yet, unless the person gets the TB reactivated because, for example, they have AIDS, then you're fine. The thing about the reactivation and the main causes of TB in the United States is AIDS, because then when this opportunistic organism reappears and breaks out of the nodules or the tubercles, the person's immune system, they don't have functional T lymphocytes. So the body has to rely on macrophages, phagocytic cells. And unfortunately, the pathogen knows how to evade death and to actually grow and divide in these macrophages. And so reactivation, in a very short period of time without intervention, the lungs can be totally destroyed. When you image it, the destruction of the lung, for some reason, someone thought it looked like cheese, so it's called caseous necrosis, and eventually that necrotic area of the lung will cavitate, or basically form a hole, and it can spread and so forth and so on. So that is TB. Cystic fibrosis is the most common genetically inherited recessive disease in the United States. It can affect young, boys and girls. And what they have, and the only thing that I will say on the exam is that they have a faulty chloride ion channel. And that is going to interfere with salt and water. And it becomes too little water, and so the mucus becomes extremely thick and sticky. and becomes a breeding ground for bacteria. So bacterial pneumonia is a very common, consistent, we have no cure for it yet. And knock on wood, gene replacement therapy would be the cure. That's not going to be on the exam. But that's cystic fibrosis. Now, acid-base. I do want you to know, and obviously, that the body wants 7.4 in arterial blood, that if you go below 7, you will do irreversible damage to the metabolic enzymes of the cell, and they cannot recover, so you die. If you go above 7, you are in alkalosis, and again, metabolic enzymes only operate in the 7 range. So if you go into full-blown acidosis or full-blown alkalosis, and you systemically denature all of your metabolic enzymes in all of your cells, needless to say, death ensues. So you need to make a buffer, because when we eat fat and when we eat protein, we make acidic waste products that get dumped into venous blood that definitely would put you out of the 7 range. So things like lactic acid and uric acid and pyruvic acid and amino acids and fatty acids. So you need a buffer. So the buffer is made in the red blood cells by an enzyme called carbonic anhydrase. And this is what it does. It takes CO2 and water, and it makes the ionized form of the weak acid form of the blood buffer, and that is carbonic acid, which is H plus HCO3 minus. Sodium bicarbonate, sorry about this, is the weak base form of the bicarbonate buffer system, and that's Na plus HCO3 minus. The whole idea of buffer is that if you have a strong acid, the weak base form of the bicarbonate buffer system will neutralize it. 7 is neutral. So, and again, if you have a very alkaline byproduct, then that will couple with the weak acid form of the bicarbonate buffer system to get you back to a pH of 7. Neutralization. And then when you get to the lung, the change in pressure is going to have you be able to reversibly form carbon dioxide and water. The CO2 goes out in an exhalation, and any water, or most of the water, stays in the body. All right. So that's the bicarbonate buffer system and why you have it. The chemoreceptors, that's just really for your own information, as far as you have these chemoreceptors that constantly check pH, CO2 levels, O2 levels, and then the medulla gets that information and adjusts the rate and depth of respiration. Respiration is the quickest way to get blood back to 7.4, because as you exhale, you're exhaling carbon dioxide, which is a source of acid. The other is sometimes when you have problems, pulmonary problems, like COPDs, you have to rely on not the lung, because the lung is not working properly. So you're getting back to 7, not in seconds, but in hours via the kidney. And the wonderful thing about that is the kidney can make its own sodium bicarbonate buffer. And what it will do is it will take the acidic hydrogen ion and the bicarbonate ion, that basic ion, and either secrete them, blood to tube, or reabsorb them, tube to blood, in order to adjust the pH. So if you had a situation where you were in acidosis, then at the kidney, you would be able to take the acidic hydrogen, put it into the urine, that's the secretion, and then take the bicarbonate ion, which is alkaline, and move it out of the kidney and into the blood. Okay, so those are the two mechanisms that we're going to play with. If it is a respiratory problem, then you're going to have a respiratory acidosis or a respiratory alkalosis. And the compensation is going to be renal. If you have what is called a metabolic disturbance, a person throws up, a person has diarrhea, and that's metabolic. Their lungs are fine. They're just vomiting and having diarrhea. And then, since they have fine lungs and your body wants to get back to 7 quickly, the compensation is going to be respiratory. So what you have are those 4 slides that I would look at, and those slides were the basis for the quiz, so that you know that your pH 7 in your body is because equal amounts of acid and base, so that, for example, if I vomit 2 liters of hydrochloric acid, I am then left being alkalotic. Or I could over-exercise and make too much lactic acid, and then I would be in acidosis, and so forth and so on. So look at those 4 slides. They go respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. And again, pulmonary problems, any pulmonary problems, the lung is not going to be able to solve a pH problem. It's going to be the kidneys. If you have a metabolic problem, the solution is the lung. It's going to be respiratory. Nervous system. Nervous system, memorize the disease and the cause, and for matching. So you know that MS is an autoimmune disease. It causes demyelination of the white matter in the brain and spinal cord. When you demyelinate, you upset the communication, and you can also destroy the neuron with ensuing symptoms. So that is the problem, and the problem with autoimmunity tends to be driven by T lymphocytes, and neurological dysfunction occurs after the demyelination. And of course, you can't remyelinate, right? All right. Okay, meningitis has to do with the meninges, the covering of the brain. And you do have a blood-brain barrier, but sometimes that does go down. And the most common is going to be bacterial infections and bacterial meningitis. You can also have other types of meningitis, but that's what I want you to know, is that if you do have a bacterial infection of the meninges, then you're going to start to do inflammation, and you're going to do edema, and that water doesn't have any place to go but into the brain and starts squeezing that brain, and so you have to medically intervene before permanent brain damage occurs. Parkinson's disease, it's an unknown etiology. It tends to affect older people. It's a disease where you see these Parkinsonian tremors. What I want you to know is that it's a neurodegenerative of the extrapyramidal system, and you end up having problems. What's the patho? The patho is that balance, like walking, having balance, and is due to 2 neurotransmitters. You have to have an excitatory and an inhibitory. And so there are excitatory acetylcholine neurons in that area of the brain that control balance, and there are inhibitory dopamine. And for some reason, there is a problem with the dopamine-releasing neurons only, but that means that you just have the excitability of the acetylcholine as the disease progresses. And that excitability is what causes the tremors. Okay, so that's the patho for that. Alzheimer's. I do want you to know that Alzheimer's actually has 2 causes, and they seem to occur simultaneously. In the brain, especially in the area of the brain, memory, cerebral cortex, there are neurofibrillary tangles, and these are going to be due to, going to be due to tau. I have to have tau here somewhere. Oh, here we go. All right, so tau proteins, right there. So for some reason, everybody has tau proteins, but they're not mutated. And when you mutate a tau protein inside the neuron of a person who has Alzheimer's, this long string becomes tangled and it interferes with action potentials. At the same time, outside of the neuron, in that area where you have the neurotransmitter and the synapse going from one neuron to another, you have neuritic plaques, also called senile plaques, and they're to a different protein that gets mutated, and that's beta amyloid. And when the beta amyloid becomes mutated, it changes its shape and makes the release and the transmission of neurotransmitters impossible. So I want you to know that it's the two of them, and that tau is responsible for the inside neurofibrillary tangles, and then the senile or neuritic plaques are due to mutated beta amyloid outside of the neuron, and it's a terrible progressive disease. All right, and we're almost there. For depression, you could write a book about depression. So the only thing I was going to mention is that very often it seems to be a chemical imbalance that occurs that causes the depression. So the one that would be on the exam would be serotonin. So a decrease in serotonin, people can take pills like Prozac, which are SSRIs, selective serotonin inhibitors, uptake inhibitors, so that the serotonin stays in that synapse longer, and as a result can rectify the imbalance. Epilepsy. Now, the main thing I want you to know about epilepsy is that it's synchronous firing in the brain that causes the seizure. A lot of times it's easy to think that normal brain activity is synchronous, and it's not. Normal brain activity is non-synchronous, and that non-synchronous firing is actually quite good because it means that you're able to imagine and envision different outcome presented with a problem. And to do that, you don't want to zero in on the first solution. And the brain doesn't like that either. The brain wants to have that plasticity. And so if it does asynchronous firing, you have more to choose from. With epilepsy, when a person is in a seizure, and I'm not going to get into the different types of seizures, but just that it's a synchronous firing that causes the seizure. Okay. And if the gods are good, that's it. Now we're on to fluid and electrolyte imbalances. For the fluid, the only one that I'm going to do is hypotonic hydration. I do want you to know that 1/3 of the fluid in your body is extracellular, like plasma. The 2/3 is actually inside the cell, intracellular. And that potassium chloride is the main salt or electrolyte inside cells, and sodium chloride is the main electrolyte outside cells, like in plasma. All right, also to know osmosis. So that salt tends not to move quickly from one compartment to another, so the body relies on osmosis to bring everything back to equilibrium. You want to have the amount of salt outside the cell, whether it's a brain cell in cerebral spinal fluid or it's a red blood cell in plasma. They want to have the equal amount of salt in and out of their cells. So if you have hypertonic plasma or hypertonic cerebral spinal fluid, that's going to draw water out and the cell's going to shrink, versus hypotonic, and the water is going to go inside the cell and the cell is going to swell. The hypotonic hydration, as the name implies, the person is hydrated, they have enough water coming in. And very often these are athletes who are in vigorous activity and sweating a lot, and they're replacing the water but not the sodium chloride, which is also present in sweat. So you have a situation that can arise where they're replacing the water, but they're not replacing enough salt. So they are hypotonic, low salt in the plasma, but they are hydrated. And that means that water will move in and you are going to have swelling. And that swelling could result in tremendous red blood cell death and can result in death. All right, electrolytes. We're going to do sodium first, potassium second. Sodium, the Latin word is natremia, can either be too high or too low. Hypernatremia, that could be excess sodium intake, or it could be due to a person who is in renal failure. The big thing that I'm going to get into on this exam is when hypernatremia is in excess. It's going to cause swelling. It's going to cause the shrinking of the neurons that are trying to be in equilibrium with the cerebral spinal fluid. And in order to have that happen, there's water loss in the neurons, and that is going to cause seizures. Obviously, if you administer water like distilled water, then that will solve that problem. Hyponatremia can be due to vomiting, diarrhea, severe sweating, heart and renal disease, but the symptoms again are going to, in extreme, are also going to be seizures, but for a different reason. So if you have too low sodium in cerebral spinal fluid, water will enter the neurons and have them swell, and that swelling will cause seizure. And the treatment is obviously give that person some sodium. Now, potassium. You need potassium especially for heart action potentials. And because the heart does not recycle its potassium but takes it directly from the blood, it's important to maintain homeostatic levels of potassium. If you have fine kidneys, that's great. If you don't have fine kidneys, renal failure is something that you have to watch like a hawk as far as their potassium levels. Hyperkalemia is too much potassium, and what happens is the symptoms are murder, and on the exam I will put this in parentheses. And too high is going to stop the heart contracting. And the treatment, I guarantee you, I'm going to ask this, a small amount of insulin is going to drive the excess potassium out of the blood and back into the cell. Now, hypokalemia, low potassium, vomiting and diarrhea are examples of that. And it can cause dysrhythmias of the heart. So the heart can go into fatal fibrillation. And the treatment is obviously give that person potassium, but also find out the underlying cause of the vomiting and diarrhea. And the last electrolyte for this section is calcium. It's not an electrolyte. Calcium is a mineral that is needed for the transmission of neurotransmitters, and also for muscle contraction and blah, blah. So if you have hypercalcemia, it's very rare. It's probably due to an endocrine disorder, but to know it causes muscle weakness and extra clotting time. That's hypercalcemia. Too high calcium, hypocalcemia, too low calcium. And that can be caused by renal failure, no CATs. And I would say, in parentheses, CATs means convulsions, arrhythmias, tetany, and spasms. All right, so that is that. And now we're into, finally, the last topic to be covered, which is renal pathophysiology. For like a 2-point question for pre-renal and 2-point question for post-renal. So pre-renal is a situation where the blood pressure and blood volume has gone down for reasons of hemorrhage or reason of water loss due to severe dehydration. And that means that you can't filter, because water moves from high to low pressure, so you can't filter the plasma that you want to purify into Bowman's capsule. That's pre-renal disease. Post-renal disease on this exam is going to be kidney stones. So you know that the kidneys produces the stones that compose of salts that have a stone crystalline formation, and they will get caught in the ureters. So you can have two things happen. You can have hydroureter, where there's going to be swelling of the ureter of that trapped urine, and that trapped urine can then end up causing hydronephros, so water on the kidney. Now, intrarenal means what's going on inside that nephron. And there are two categories. Is it the tube structure that's being attacked? Or is it the glomerulus Bowman capsule being attacked? So for the tubular disorders, there's going to be one example, and that's going to be acute pyelonephritis. And for the glomerular disorders, there's going to be two examples, strep-induced glomerulonephritis and Goodpasture's syndrome. So in acute pyelonephritis, it's usually a urinary tract infection, and most urinary tract infections are caused by these gram-negative organisms. And what will happen is you'll have a reflux of the infected urine up the ureters into the kidney, especially the medulla. If it's treated right away, you're fine. If it causes scarring or atrophy of the tubes, then that's going to cause permanent damage and loss of the function of that nephron. Under glomerular disorders, glomerulonephritis is a kind of a term which refers to the filtration of a certain amount of plasma from the glomerular capillaries into Bowman's capsule. And then that filtrate would then go into the tube structure of the nephron, where you could adjust for blood volume and blood pH and electrolyte and get rid of toxic waste products and so forth and so on. So the two types, streptococcal glomerulonephritis. So this is going to be where a person having a strep throat, the strep throat is treated by antibiotics, but if the antigens pathologically, the strep antigens pathologically fall on the basement membrane of the glomerulus, it causes inflammation, and that inflammation can be deadly to the nephron. The other has to do with Goodpasture's syndrome, which is an autoimmune disorder in which it only affects men. Autoantibodies are formed against the glomerular capillary basement membrane. So again, you're going to get inflammation, and that will destroy the glomerulus and Bowman's capsule, and that means that entire nephron is down, and the person is down a certain amount of renal function. All of those are acute. Now, let's get to chronic. The only two chronic that are going to be on the exam is going to be diabetic nephropathy and systemic hypertension nephropathy. Both of them can lead to end-stage renal failure, but the pathophysiological mechanism is different. In diabetic nephropathy, because of chronic hyperglycemia, that is going to remodel the cells of the that is found in the glomerulus Bowman capsule, called the mesangial cells, and they start to malfunction, so that the person is going to have a lower glomerular filtration rate, lower urine output, and as the mesangial cells become less functional, then you can have total destruction of the glomerulus with loss of function. On the other hand, systemic hypertensive nephropathy has to do with the long-term vasoconstriction of the arterioles. And that means that the arterioles, like the afferent arteriole that's feeding the cells of Bowman's capsule, they over a period of time, they become hypoxic because they don't get enough oxygen and nutrients to do their job. In addition, the efferent arteriole that feed the rest of the cells of the tube structure of the nephron also becomes starved over a period of time of oxygen, get rid of waste products, and they will start to die. So the main thing with the systemic hypertensive is the destruction of the cells comprising the nephron, versus diabetic nephropathy is the remodeling of a mesangial cell that will lead to inflammation and the destruction of the glomerulus. All right. Last slide. This like 2-point questions. I just do want you to know that when you have renal failure, very often, like say with acute renal failure after a person might have hemorrhaged, then they would take bloods and find that the waste products that normally are in urine stay in the blood because of a problem, in this case, of blood pressure and blood volume. So the BUN value means blood, that you're taking it from the blood. Urea, nitrogen, and creatinine are waste products that should only be in the urine, not in your blood. They're poisons. They can lead to uremia poisoning. Chronic renal failure, because it's over a period of time, that's where very often the person will have to be on dialysis. And the thing that they worry about is uremic poisoning or uremia, and chronic anything, chronic glomerulonephritis, chronic pyelonephritis, all of those, because they affect the permanent destruction of the nephron, can eventually lead to enough renal failure that the person has to be on dialysis or die of uremic poisoning. And that's it. All right. So, and I'm sorry about the interruption. And I will look forward to seeing you on Monday.